got these.
We had a. Now that you said Kasha was in your dog.
Kasha. It's K-A-S-A, but we pronounce it Kasha.
We had my dad had a Siberian Husky. His name was Tishka. Very close.
Kasha is some type of an American Indian, which I can't remember which one. It's supposed to mean house, home. Not hot, but like casa is house. It's supposed to be something like that. But not Spanish. A-S. With the S being a sh instead of S. Sometimes it's, well, in the beginning we spelled it K-A-S-H-A for some people, but the papers it's just K-A-S-A. And the other one is laying here at my feet. He's giant, and he's F-L-A-S-H, but I can't say his name because if I do, he will jump up.
But they're supposed to start to share cat pictures on their page because cats sleep like my kids do. It's pretty
Do I
hilarious.
not have you on Facebook? I guess I don't, because I've never seen.
The cats are spooning. It's kind of weird. How they sleep during the day. Okay, 10 seconds. Finger on the thing. I feel like I forgot.
I'm gonna bring a page or two over once or twice, but it's always worked before, so I don't. And my internet's good.
Good. Okay, in 3, 2.
Hello, everyone. It is time for case studies. Love the case studies. We have so much fun. We try to take a particular area or a topic and then just break it down and do practice. I think I'm trying to remember what the last topic was. It's been so long. Tonight we're going to talk about abstracting E&M, and I just realized I don't have my question box up. I better put that up just in case you guys want to ask some lovely questions. The difference that this webinar is going to be is that, yeah, we're going to talk about E&M and break that down, but we're going to actually talk about abstracting the information. We're not going to necessarily talk about, how to determine, how to do bullets and so on and so forth and count points and everything. No, we're going to talk about how we look for and abstract the information in the documentation. Look for those key words, those magic words, so that we can determine the E&M. This is something that takes practice, but after a while it just clicks for you. E&M is an area in coding that everybody struggles with. So your code range for E&M goes from 99201 all the way over to 99499. The E&M stands for Evaluation and Management. It doesn't matter if you're inpatient or outpatient. There are areas of E&M that can be done. What's mostly talked about, though, is outpatient E&M. I think overall, and the reason that is because when we talk about reimbursement in the outpatient realm of coding, it's heavily based on E&M, the evaluation and management of the patient. Whereas for inpatient coding, it's the diagnosis that establishes reimbursement for the facility. But there are E&M codes that are associated to inpatient. We're not going to look at those in depth, though, because that's another study. We're going to talk about actually abstracting. So if you look at this as an outpatient, your first thought process, and we'll do some others too, but it is for family practices especially. This particular quote I thought was telling. It says, okay, if you've got a family physician or even other qualified providers, then you can maximize the payments if you understand how to document for E&M. Now, it's not that you're documenting to get reimbursed. No, it's so that you're documenting, the provider is documenting with those key and magic words with the work, the evaluation and management that's being done and taking all that information from their head and getting it down on paper, so to speak, even though we're not really using paper per se anymore. You know, there is, as we get through a couple of these slides, you know, it's one thing to say that, you know, I spent 15 minutes in, you know, face-to-face with the patient. That's not going to be enough. For really good E&M, you need to say that I spent 15 minutes face-to-face with the patient, evaluating a change in medication, the signs and symptoms that were complications for the previous medication that was on, and answering questions for the patient. Okay, see that spells it out. Now, you know, the providers know they did this, but they're just saying, well, I spent 15 minutes. That's how I get paid. No, you get paid for the face-to-face time, but we need to know what that time was spent on. Not, I spent 5 minutes doing this, I spent 10 minutes doing this, no. You need to just say, I spent 15 minutes face-to-face with a patient. That's not the nurse coming in and kind of doing the beginning documentation as to, you know, what's your chief complaint, anything specifically you want me to bring to the provider's attention before they come in, you know, is all your medications the same, if pharmacy change, you know, let's take your vitals, so on and so forth. That doesn't count. It's the provider's face-to-face time with the patient that is going to, the E&M is based on. All right, so let's just jump in and let's look at some of the things that we'll be needing to abstract from the cases to get the proper E&M. We need to do the history, the exam, and the medical decision making. So in the history, we're going to be looking at the chief complaint. Right? Why did the patient come in? Because they have a sore throat. Because they got a new medication, and this is their follow-up on the medication to make sure that everything's working, you know, all right. And that is the chief complaint is not follow-up, right? The chief complaint is follow-up on, you know, change of dose in, you know, triliptol. Dosage change in, you know, hypertension medication, right? It's not to follow up, which that's what it is, but that's not enough information. We need, the documentation needs to really spell that out. And as liaison and educators for our providers to help to work as a team, you know, sometimes we need to pull that information from them, let them know how a higher specificity really is helpful. So our HPI, history of present illness, the PFSH, of course, is the personal, family, and social history, and the review of systems. All of that we can establish history in. Then we have our exam. The exam is the hands-on part. So what's the constitution of the patient? What is the MS? What's the psych maybe that we're doing? Then medical decision making. Is it a new problem or an established problem? Right? What's the data? So what's the data that I need to review? What, as the provider, what's the data that I need to document on? You know, it's one thing to look at the labs and say the patient's HbA1c is a whatever it is, but, you know, put in there what it was last month, what it is now, and what your concern is, right? You know, ideally. And then what's the risk? The risk is part of the medical decision making as well. So I kind of did this backwards. I've got some things in that I want to pull over and let us look at, because part of the things that I want to do is to kind of help you research and get some practice on your own. It's one thing for me to just tell you, this is how you do it. No, you need to get out there and get those little spidey senses of yours for coding working, or develop those coding muscles, right? So this is a scenario or a case study that we're going to look at that I found that is a 99213. Okay, so why is the patient being seen? What is the scenario? We have an office visit. This is an established patient. It's a 9-year-old with ADHD, mild symptoms, minimal medication side effects. Okay, so that's the initial basis of what we know about this patient before they come in. Okay, and I'm just telling you it's a 99213 ahead of time. Sometimes I think, well, one, I think it's very important to make mistakes. And when you take tests and stuff, if you miss them and then you look at the rationale, and if you understand why you missed it, you probably won't forget it. And other times I like to kind of a teaching technique is to teach backwards, give you the answer, and then let's go back and establish why the answer is the way it is, right? So this is a 99213. We're going to have two of them that we're going to look at, and we're going to divide it up. So the history, this is what's written in the documentation for the history. We have a 9-year-old male seen for follow-up visit for ADHD. Notice it just isn't a follow-up. No, he's a follow-up visit for his ADHD. The visit attended by patient and mother, that's pertinent information. The history obtained from both. So the child was given questions and information was asked of the child and also of the mother, right? That's pertinent. That establishes a lot about the patient, that the patient is a good historian, is able to establish credible answers. Okay, so it goes on to say grades are good, but patient appears distracted in class, lunch appetite poor, but eating well at all other meals. Then the psychiatric component denies depression, anxiety, or sleep problems. So what is our associated signs and symptoms? So we know the patient has ADHD, and the associated signs and symptoms are going to be that our grades are good. That's a sign and symptom. That's excellent, because a lot of children with ADHD don't get good grades, and it's because they can't seem to focus in a standard type of testing atmosphere or even pay attention during a class period. You know, sometimes you get scored on just being present, but it also is contribution to a learning atmosphere. You know, do you raise your hand and ask questions, et cetera, right? That makes you know that this person is kind of able to function in the classroom and is obviously not struggling with the grades. All right, so what's our quality? Appears distracted. That's a quality that we're able to abstract from this documentation. And what's the context? It's in class. Okay, so we have associated signs and symptoms, we have quality and context, and we got it all in one sentence. So grades are good, that's associated signs and symptoms. Appears distracted, that's the quality. And then where's it all happening? In class. So does the patient have problems at home too? Okay, this isn't addressed because, you know, a lot of times, and maybe it's addressed at a different time, but ADHD children, to their own devices, not having to sit in a structured learning environment, usually are perfectly fine. So lunch appetite poor, but eating well at other meals. And again, you could pull that, but we've got everything we need in that first sentence. So for the HPI, which is where we're pulling this, we've got three elements. We've got associated signs and symptoms, quality, and context. Three elements that we've already abstracted. What's the review of systems? We have one review of system, psychiatric. Okay, so again, what does that tell us? We're moving on to the exam. Now, with the exam, we have appearance. So we're physically looking over the child. Appropriate dress comes to office easily. So you call the patient, the mother and the child walk up to the nurse and walks up into the room. The doctor's standing there and says, "Hi, how you doing, little Johnny?" And you know, and they go in. That means that Johnny isn't bouncing off the walls as he's, you know, coming in, or being distracted and can't walk in a straight line because easily attracted to other things happening in the room, so on and so forth, right? So appropriate dress comes in the office easily. Speech, normal rate and tone. do you think of that, right? But that is part of the exam. And we have to think of signs and symptoms. Again, what do we know about ADHD? It helps you to understand disease processes, to abstract encoding. So I have an ADD child, but I never had an ADHD child, which is that hyperactive component. So normal rate and tone. So we don't have a child that's talking way too fast, and their tone, they're not too loud. Usually they're too loud. Very seldom is ADHD children very quiet. And then thought contact. We have no SI or HI or psychotic symptoms. Okay. Associations intact. He's orientated ×3. Mood and affect. Euthymic and full and appropriate. So again, we're going to do the examination scoring. We got 6 elements, which is expanded problem focused. Okay. 6 elements. Now the medical decision making. We actually have one problem. What is being treated? The ADHD. Okay, so with medical decision making, it matters how many diagnoses, things that we're evaluating, right? So we have medical decision making for one item, one diagnosis. And with that, we have the comment, oops, hold on. Boy, you have to tell me if there's a problem with my internet. It seems to be fine on my end. But so what is the comment that's given? So this is like the diagnosis and the plan. So our comment, relatively stable, mild symptoms. One problem, and then establishing a higher level of specificity within that diagnosis, right? Plan. We're going to renew a stimulant script and increase dose, and then return visit in 2 months. So what is our scoring for our problem? We have one established problem and they're stable. So that's a minimum. They get 1 bullet for that, and it's minimum. One thing wrong. When you're talking about the data, which we talked about in the list on the previous slide, we've obtained a history, and not only did we obtain it from the patient, but also the mother. So that's 2. We get a total 2, which is limited. And then the risk scoring. Well, this is a chronic illness, right? ADHD is a chronic, and it has only mild exacerbation from what they're still having effects, right? Appetite is something that they talk about. So appetite would be a side effect that could be problematic, but the child's eating outside the home, just not much at lunch, probably because they're easily distracted. A lot of the medications that's given to ADHD children is stimulants. So like even caffeine is very good to calm down an ADHD child. And but the side effect of that is that their appetite is suppressed. And so their weight is something that you watch very, very closely. And so we have mild exacerbation because they're still having trouble in school, but their scoring is good. They're still able to get good grades. So we have a mild exacerbation, progression, or side effects. And so we do have a slight side effects. And then prescription drug management, and that's moderate. So again, we have minimal, limited, and moderate. An established patient, we only need 2 of 3 when we're getting the final E&M score. And that was supposed to be taken out. All right, so do you see how we got a 99213 off of that, right? So this is another patient that is psych also, and it's also a 99213. And they're a patient that's coming in for their visit, 27-year-old, and established patient with stable depression and anxiety. So they have depression and anxiety, sometimes they lump that together, and intermediate moderate stress. So now we know why the background of the patient. Let's go over the things for history. And the documentation tells us we have a 27-year-old female. Okay, we already established that. It's a follow-up visit, but why are they here for a follow-up? It's not just a follow-up, it's for depression and anxiety. Okay, and it's just the patient coming alone. That's pertinent, right? So the patient's the historian. So we're going to get our severity is difficult at work, but coping has been good. Okay, minimal situational sadness. So we've got severity and we've got quality, right? And anxiety when stressed. So that's context. So of course, when is the patient most likely stressed? At work, right? Could they be stressed at home? Yes, but they're giving us context that when the patient is stressed, then they get some anxiety, and that they're saying they have a little bit of difficulty at work. So we have minimal, we have situational sadness, and we have anxiety when stressed. So that gives us severity, quality, and context, 3 elements, and that's brief. So those are how we're abstracting those elements. Review of systems, just 1, so it's problem pertinent for the history. Okay, see how we're pulling out the little bit of information. We're going to do some bigger things here in a little bit, but again, let's practice with the small stuff first. So exam, again, this is the physical looking at the patient and touching the patient, so now this isn't the opinion of the patient, this is the opinion and touching and what the provider actually sees. So in appearance, where appropriate dress appears stated age. Now, that is an easy way to describe that a patient is looking normal. If they were depressed, maybe they would be dressed like they were not taking care with their appearance. Their hair is pulled up in a messy pigtail and doesn't look like it's been brushed, makeup or makeup not taken off from the night before, sweatpants and a baggy shirt and tennis shoes, might not be appropriate dress unless you're not feeling good, right? So appropriate dress for somebody that had signs and symptoms of the flu is going to be something that you probably don't even consider. Whereas this is a regular doctor's visit. What should, did you just come from work? Whatever, and really actually appearance is one part, but do they look their stated age? Because if you look older than your stated age, if you look much older than 30 when you're below 30, and that could be a sign of stress, right? That your complexion's tight, maybe wrinkles, worry lines. And I'm not talking about like beauty things, but there is stress ages the face and tenseness in the body. Or when you're dealing with psych, it could be the opposite. If you have a 27-year-old female who is, having emotional issues or whatever type of psych issues, and they're dressing like a 15 or 16-year-old, that's not appropriate. Right, there's a disconnect there. That looks like, what's going on? You're almost 30, and why are and again, this is all stuff you take with a grain of salt, but these are things that you can abstract. And when you think about what we're dealing with psychiatric. So appearance, these are things that you could pull out to get your elements. Speech, normal, rate and tone. Thought, content, no SI or HI, or psychotic symptoms. Association is intact, orientation ×3, mood and affect, just almost the same as what our previous patient. So this tells me that this is the same provider probably as our previous case. And we have appropriate judgment and insight is good. Okay, so we have 7 elements that are touched on, so it's a expanded problem focus that we're abstracting. Medical decision making, we have 2 problems this time. So that raises the medical decision making. Problem 1, we have depression, and the provider states that it's stable. So stable depression. What are they going to do? They're going to refill the SSRI script, and it's going to maintain the dose. Okay, and they're going to return in 3 months. Now, problem 2 is anxiety, also stable, and again, same dose of the SSRI. So the medication that the patient is taking for both diagnoses is the same medication. However, we have 2 diagnoses. Just because the treatment for both is the same doesn't mean that we can't have 2, 2 separate points there. Because there's a lot of times the treatment can be the same for 2 diagnoses. And, having them return in 3 months lets you know that it's an ongoing thing. So for our scoring, we have 2 established problems, and they're both stable and limited. So that's a 2. They get 1 for each, a point for each one. Minimal risk because they're stable, they're chronic, that's okay. And prescription drug management, we're going to keep everything the same. So that's moderate. Right? So they're on a medication that has to be managed, but it's working. And so we're going to keep them at that level. So we're at a moderate. Okay. And so that gives us a 99213. Okay. That's an example of 2 separate cases and how we abstract. Now let's look at another case study. Let's talk through a SOAP note and how we're going to abstract the information from a SOAP note. And again, I'm not going to explain what a SOAP note is and all this other stuff. That's all in a different video. Okay, no problem. So we have an established patient, and they are coming in for a visit because they have cold symptoms and they're a tobacco user. So the fact that we know that about the patient, okay, is pertinent, and we know what they're going to start looking at, right? So we have a 25-year-old male. So the chief complaint, the chief reason why the patient's coming in, we have runny nose, congestion, ST, cough. Okay, so the patient, again, common cold symptoms, right? Now, what do we have to get? We have to get what's the problem from the S part of what's the patient telling us. So we want to get a history, right? We want to find out how long the patient's had this, what is the quality or quantity, all of those other terms we're trying to pull out of this first section that we talked about previously. So we know the patient has signs and symptoms for this common cold. But notice here that the patient not improving, so that gives us quality, right? And what have they done to make themselves better? It's been a week. They've tried Tylenol, cold and flu, okay? And it's not working. And then notice here, son has similar symptoms at home, right? So again, they're not just all alone. Somebody else in the family is sick. That also gives us a little bit of context of what's going on. Happened 1 week ago. They started getting sick, so that gives us duration. Cough is non-productive. Well, that can be classified as a quality, but again, if it's productive versus non-productive, tells us quite a bit about the disease process and the decision-making that's going to be made as far as a diagnosis, so that's pertinent. Symptoms mildly affecting sleep, because what happens when you go to sleep when you have a cold, right? You can't sleep because you can't breathe through your nose usually, and you're draining, and your throat gets sore. And then we also have congestion. So it is mildly affecting sleep, but anytime you have congestion when you go to bed, because what happens, you lay down and your nose goes, it feels like it just swells up, right? Then we have a review of systems. No recent flu or cold, and the patient doesn't have nausea, vomiting, or diarrhea. So, no, I'm sorry, that's not fever and cold. That is uh, uh, that is not F&C is fever and chills, not fever and cold. I didn't read these in depthly before I did them. I should have read them a little more in depth. But another thing that I really like about this one, and this is probably a handwritten one that was put down because you don't use that much abbreviation necessarily when you type. So I do, but not everybody does. So again, that's pertinent, the review of systems, because for the disease process, we know if the patient has nausea, vomiting, and diarrhea, and they don't say they have a sore throat, but when you have those in association to a sore throat or cold symptoms, a lot of times it could be strep. Okay, and fever and chills, also means that it tends to be well, it can be viral or bacteria, I guess, and have that, but definitely a fever makes a difference. It lets us know there's an infection in the body. Social, they're positive for tobacco use. Occasional, OCC, occasional alcohol, willing to quit tobacco within the next month, has been considering for some time, tried once prior last year, but relapsed. Okay, so in other words, we know that some counseling is going on here, are going to go on because the patient wants to try to stop smoking and understands that smoking exacerbates all this stuff. So now we're getting into the objective. We're going to start reviewing the systems here. We've got regular vital signs. They all look good. Tympanic membrane is TM, shiny gray, and landmarks. So it looks fine. No DC, and OP is pink. Some cobblestones, no exudate. They're looking at the back of the throat. And then the neck, no LAN. Lungs are CTA bilaterally, and normal rate and rhythm. No murmur is what that means. And now we're going to get into the diagnosis and plan. So they diagnose with a URI, which is an upper respiratory infection, which we knew that was probably coming, right? So patient education and reassurance, they're going to, one thing is patient education on, well, is it a virus versus a infection, and if they were to give them a medication, what am I going to give you, an antibiotic or not? They don't usually give an antibiotic unless you have a fever and chills necessarily. So again, patient education, and I love that they said reassurance. Verbally, they told them they're going to get, the patient states that they verbally understand, and then the prescription is deconamine and SR, which is sustained release, and is a medication for congestion in the cold type thing. They're going to give them, that just talks about how many pills they're going to give them. So follow up if symptoms worsen or persist in 7 days. Now, notice here, tobacco abuse preparation stage. So they're going to give also counseling. So they talked about the tobacco abuse and then counseling on cessation of cigarette smoke. Why do they smoke? Because, is it stress related versus habit, and techniques to quit? And then also let them know about a local class. All right, so now look at all the things that we can abstract for them. We know they're an established patient, so we're going to be able to go with a 9921, and it's not going to be a 211, 212. It isn't going to be a 213 because we have two things that they did. Talked about stopping smoking, and then they've got this cold. Okay, and the medical decision making for both of those is up a little bit more. So what we're abstracting is how many diagnoses do we have? We have two. We have treatment and medical decision making that went into both of those in diagnoses. And then when we look at the history and everything from that HPI, review systems and social, that's a little bit higher, but we still only have the two diagnoses. So let's kind of look and see what decision making some of the experts came up with, and then talk about why they came up with those. Okay, because that's going to help us with our abstracting. So they asked more than one reviewer. They did 4 reviewers, and they decided that it's probably a 99213. So let's break down what they were thinking. 4 of them agreed that in the documentation that they could abstract the history and exam could give them a 99214. It could, because we have enough of that history and in the exam, the stuff that we just talked about. But really, the presenting problem, and it's cold, right? And the patient's already been smoking for a while. So, even the medical decision making, probably not enough to give them a 99214. So even though the new diagnosis of a cold, that's a new diagnosis, but it's really not that big of a deal, is it? People recover from that pretty quickly. He didn't get an antibiotic? Would he gotten better on his own after a while? Probably, right? Now, if you're going to stop smoking, they already knew that the patient smoked, right? And so really, they're just giving them a little encouragement about stopping smoking. They're not giving them medication or anything. It's mostly just counseling. So that it would really probably be easier to go with a 99213, justifying that. And the 5th person that they looked at it definitely said, when you have this history and the decision making supported, only the 99213, no higher. And a lot of that, I think, is based on the disease process. Now, if the patient had a new diagnosis of hypertension versus they've got a cold, and they smoke, that's different, because the medical decision making that goes along with a chronic condition like that is much higher versus this person has a common cold, right? And they just happen to smoke. So it's better to the information that we abstracted. Now, if the patient had asthma or another comorbidity that went along with a common cold, that would raise that up to a 99214 probably. But what we were able to abstract out of here, not really. Okay. So now you see kind of the different things. Oh, let me go back. Hold on, I'm not ready to show you that slide yet. So what I want to do is show you a couple things that I was able to go and look at. And we're going to do a couple of these together. Let me see if I can get this big enough. So this is where I got that first case, the first 2, the 9-year-old and the 27-year-old. And don't worry, I put these at the end in the resources, these links. So don't be trying to write these links down. Oh, this is a really, really good website, the AACAP. They have a lot of really great practice stuff. So let me just make this a little bit bigger here for us, because that's really pushing my eyesight. Let's see if I can get that to. Oh, no, I was hitting shift instead of control. See if it'll make it bigger. Because I want to, no, I don't want to print. Do you know, I'm talking to myself. Control plus, there we go. Not make it too big. Okay, let's kind of look at some of this stuff. I want to give you some more examples, because this is a teaching tool for providers, and there's more than one practice on here, and I like the way they divided it up. So let's abstract from this. So that was the first case. Now the examples of 99213. Now we're going to look at some 99214s, and let's pay attention to what is abstracted here. And again, another reason why I think this is so valuable is notice that the pink or the light color that they're using is right after what they're abstracting. So I think it's again a great teaching tool for us as coders. So let's look at the left side for the first patient first. We have a 13-year-old male established patient. These are all established, I think, with depression, anxiety, and anger outbursts. All right, so we got 3 things happening with this patient. And the chief complaint just more or less establishes what we already know. But let's look at the HPI. We end up with 6 elements that we abstract. We get timing, severity, quality, context, associated signs and symptoms, and then we get modifying factors as well. And timing. They are reporting an increase in moderate sadness. Okay, so that gave us timing, severity, and quality. Boom, right there. And we're not even out of the first sentences. That seems to be present only at home, gives us context. And then it goes on, tends to be associated with yelling and punching the walls, associated signs and symptoms, right? At greater frequency. And then we'll go down to the last sentence. Anxiety has been improving and intermittent with no evident triggers. So again, what's the modifying factor here? Well, their anxiety is improving, and doesn't seem to be triggers that are setting them off. So that's good. So again, we have 6 things that we get from that HPI right there. Now we're still not done with the history portion. So now let's go look down 8th grade without problems, fair grades. Okay, so that gives us the PFSH, 1 element. So it's pertinent. Then we get into the review of systems. We get a score of 2 because there's 2 symptoms. We did psychiatric, no problems with sleep or attention, and neurological, no headaches. Okay, see how we got 2 there? All right, now let's scroll down just a little bit. So now we're going to get into the exam. With the exam, this is not all, you know, written out as far as color coded like before, but we've got nine elements. So we've got speech, we've got thought process, associations, we have thought content, we have orientation, let's see, attention and concentration, and mood and effect, and judgment and insight. Now, the thing about exams is they're usually just bulleted out. Okay, so they're pretty easy to do. Now, this format is a little bit different because usually it's bulleted out like that. But again, or if you're EMR, you might have those highlighted in bold. That can be beneficial when your eye is scanning to abstract. Okay. So we've got a detailed exam. Medical decision making. Notice we have 3 problems that we mentioned before. So we have depression, we have anxiety, and we have anger outbursts. Three different things. Now, instead of reading this out, let's talk about what he's going to do for this patient. 1, we are increases SSRI, and he's going to try a CBT therapist, and he's going to return. Okay. Anxiety, going to be working with a therapist. Okay. And then the angry outbursts, we are going to call therapist, they're going to, in other words, we're calling a colleague, right? And we're going to let, we're going to find out if there's some additional history that we can apply for treatment by conversing with a therapist. We're also thinking about a new medication, and if there's no improvement in the next couple months when they come back. Okay, so problem, we've got 2 established problems and 1 let's see, 2 established problems, and then we have 1 new problem. No, established problem improving. I'm sorry, that gives us our 3. So all 3 of these were something that already existed, and 2 of them are getting worse, but 1 is maintaining. That all makes a decision. Those are key things. Those are magic words. Is our patient maintaining with an established diagnosis? Are they getting worse? Or are they getting better? Okay. Let's see, the data is, again, just obtaining the history and stuff. That there's multiple things that they do. And the risk score, we have, if you have more than 1 chronic condition and there's an exacerbation, then that bumps everything up. And we have 3 diagnoses and 2 of them are worsening. Right. So again, that gives us our 99214. Let's talk about this patient on the other side. This time we have a 70-year-old patient, stable depression, recent mild forgetfulness. So we're not going to, again, let's pay attention to what they flagged as things that we need to abstract. Notice we have duration, timing, severity, quality, modifying factors and associated signs and symptoms. So we have 6 things that we're going to be able to abstract in just this HPI. So we've got some distress, and he's repeatedly lost small objects, and then he lists some of the things that were lost. So that, and how long has it been happening? Last 2 or 3 months. Duration. Patient notices intermittent, that's timing. Mild, severity. Forgetfulness, quality. People's names and some other things. Modifying factors, no particular stressors. Right. So if you don't know what could be modifying factors, what I would do is take some time and do a Google search, modifying factors in, diagnoses, or modifying factors in HPI. And then you'll probably get a list. HEMA is really good about listing some of this stuff. Let's see. So we got a 6 elements, right? We did. Less attention to hobbies. Ooh, that's PFSH. Okay, so personal history, not as interesting. Not as attentive to hobbies as there were in the past. And then our scoring for review of systems, we have 2 body systems, psychiatric and neurological. You know what? It doesn't even matter that they have a problem or not in this area when you're abstracting, because look, psychiatric, no problems with sleep or anger. Okay, it's the fact that it was addressed, so it gets to count. Okay, and then neurological, no headache, dizziness, or weakness. The reason review of systems is important like this is because it puts the provider in and answers questions on whether we're going here or there. Okay, with a diagnosis. So the exam, we have 10 elements in the exam. So let's talk about those because they're not bolded or anything. We have appearance, we have muscle strength and tone, speech, thought process, associations, thought content, orientation, attention and concentration. Let's see, mood and affect, and recent and remote memory. Now, let's look at some of those key words. Speech, normal, okay? Normal rate and tone. We've seen that in some of the others. That's a common, obviously this provider likes to document that way. Thought process, logical. Okay, that's an interesting way to say that. Associations, intact. Thought content, okay, is, in other words, they're not thinking about suicide and stuff or psychotic symptoms. Orientation, times 3. And if you don't know what orientation times 3 means, that means they're, alert, know place and time, things like that. Okay, then attention, they're unable to focus on serial 7s. Now that's interesting. And then their mood is all appropriate. Again, it doesn't matter if it's a negative or signs and symptoms that they have. It's just the fact that it was addressed, you get to count it. Because sometimes you'll see it and it'll say speech and then it'll say NA. Well, if it's not applicable, you don't get to count that because there's no documentation there as to what they found. It means it's not applicable, so it wasn't counted. So pay attention to that when you're abstracting. All right, so we have 10 elements. We're still in the detail, but now let's go down and we see we have 2 problems, depression and forgetfulness, right? And then what are they going to do about it? Both of them, let's see, depression had for a while, but it's stable. But the forgetfulness is a new diagnosis. Okay, and so what are we going to do about it? They're going to do an MRI, and he's going to get a consult or maybe refer to a neurologist if it persists. So our problem scoring, we have a 5 for extensive and total of 3 for data scoring, and risk scores moderate. Right, so we got our 9921. Well, we've got enough time to look at another one, but again, here, this is a lot more fun. This is a lot more in depth, and you can find other sources like this. These sources are best found when it's for provider education. There's stuff out here for coders, but this is for a provider to learn how to document. And so, and see how it plays such a great part in what we do as coders, and that because we speak the same language, more or less. So I wanted to show you that, but let me look at another thing that I wanted to show you here. I wanted you to be aware of. This is a great site. It's a great article, which I know I've shown before in a lecture because I had it bookmarked, but it's way back in the early 2000s. And so sometimes codes will change, and everything. But again, this is teaching. No, it's not this one. This is one I'm doing for another lecture. Sorry, that's compliance. This is it. Same website. Good stuff. You see how I do my research. Test your coding skills. The scenario in the beginning where we had several opinions, all right? This is going to do a list of different scenarios, and then they ask the experts, like 5 or 6 experts, and say, okay, now how would you have coded this out? And then they give their opinion as to why. And this really, really is helpful for you to learn how to abstract. But the other key is it's just not the basic provider E&M for new and established patients. There is other ones in here that you may not have been familiar with. So this is 2002. Be very careful when you do this. This talks about what they did, who the reviewers were, and who they checked in with. So we have a progress note. Now I picked, this is the one that we did together, that I put on the slide, progress note 2. Okay, but these are all listed so you could go through them and make yourself notes, right? So you have 3, again, established patient, but look, hernia, chronic conditions. And then here, annual exam, chronic conditions. Look, they even put codes on there, which don't worry, these codes might be off just a little bit because this was way back in 2002. So you're going to have ICD-9 there. Don't let that freak you out. New patient office visit with chest pain. Right, and then 6, office visit, annual exam. And then here's the recommendations. So this is how they would have coded this out, and the things that they abstracted to come up with those decisions. Great website. I like this website. This is one that again, I've used this particular link before, and this is a great site for you to get current stuff as well. And and I like that they have some quizzes in there. Right. So you can see I've favorited them and I get information for them. Another one that I wanted you to be aware of before we wrap up, again, this is E&M coding, what not to do. Now, the date on this one, I think I have to go all the way down to the bottom to, yeah, this was 2014. And again, that's significantly different in date. So always pay attention to that. But what they did is they divided up some of the areas in E&M that have a problem with documentation. Whenever you do anything that's CDI work or documentation work, that that the provider is being educated, you can use that as a tool to help yourself come up with the verbiage to abstract. So that's pretty key. I would take advantage of that and bounce off of these other links that they give you. Okay. Whenever you see anything like that linked, it means that they're going to have something else. But this is one to tell, this site is telling you, hey, this is where there's common problems and what there is, where the problems are, not only for E&M to just in general as a coder, we need to learn to abstract. It makes us a better coder because we get to a higher specificity for statistics, and then it also makes us faster. Right. And it's not that we get paid by the chart all the time, but still it is a lot of us have in the past or in the present, production coding is still important, right? And you want to increase your skill sets. So when you know what the problems are, often, even if it's CDI work, having this to go back on really helps you. Okay, I'm going to get rid of these over here. And then I want to, this is a great tool. Again, you can download that, practice that. Wanted to show you something that was new for 2019 that had to do with E&M, Medicare, because there are some changes that are going to maybe happen to E&M. But again, we're not talking about it here necessarily. But whatever Medicare does, everybody else follows. So Medicare said that the provider, when they're doing document review and they're verifying anything that's, the history in the medical record, and it's stuff that ancillary staff like the nurses or the MAs have put in, and if it's beneficial, instead of having to re-enter that information, and it's an established patient, not a new patient, that they can now refer back to that, and it doesn't have to be re-entered. So, that's kind of before we've never been able to do that. Okay, so Medicare is saying more or less here that if you have an established patient and the nurse has documented all of this stuff, you can go back and more or less refer to the nurse's note and don't have to retype that all in. That's kind of different. And if Medicare is letting them do that, it's because we're not able to code off what the nurse says or the physical therapist per se, except for like staging things, like staging and BMIs, staging of pressure ulcers or BMIs. We can do that. We can say, okay, well, the nurse put that the BMI is a 52, and the doctor diagnosed the patient as the patient is obese, so I can go ahead and use that BMI, right? So things are changing a little bit there. Here's the resources that I used. And again, if you are in our CCO club, you'll have access to that. You just go in and, oops, I should have changed that this was 19. I'm sorry, I'll get that changed. Don't forget, you can ask questions at the CCO club. We always give them priority, our CCO club members, and you have all the other SMEs. E&M is a place that we struggle, but if you become very effective in abstracting content, not just counting off those bullets, right? But learning how to abstract and where to find things in the documentation, E&M becomes a lot easier. Okay. Lot of little components to it, but the more you do it, the faster and the higher quality you get in doing it. All right, guys, thank you very much. I'll see you next time.